Did you know that 77% of depression diagnoses in primary care could be wrong? Today we'll discuss how a well-intentioned quality measure is forcing doctors to potentially misdiagnose and over-medicate millions of Americans. Welcome to PCP Lens, where we journey through metrics, money, and madness. My name is Sudeep Bansal. I'm a primary care physician in Connecticut and I run my own medical practice. In this video, we'll look at the details of depression screening and follow-plan quality measure, how it leads to overdiagnoses and overtreatment, and the burden it places on primary care. Let's dive in. The definition of depression screening and follow-plan quality measure is the percentage of patients aged 12 years and older screened for depression on the date of encounter or up to 14 days prior to the date of encounter, using an age-appropriate standardized depression screening tool, and if positive, a follow-plan is documented on the date of the qualifying encounter. It's a mouthful. Let's break down the quality measure into its individual parts. First is the denominator, which defines the total number of eligible patients, which in this case of depression screening includes anyone over the age of 12 who's had a valid patient encounter based on a billing CPT codes in the last 12 months. To meet the criteria for numerator, a standardized depression screening tool such as a PHQ-2 or PHQ-9 should be used. Depression screening should be performed on the day of the encounter or up to 14 days before. If the depression screen is positive, a follow-plan should be documented. If a person has a known diagnosis of bipolar disorder for which the patient was seen by the doctor in the last year, then the person is excluded from the metric. Next is denominator exception, which is different from exclusion. In this case, people are removed from the denominator only if the examining doctor justifies that it is not medically appropriate or just doesn't make sense to put the person through medical treatment for depression. So for example, a patient refused to complete depression screening. An appropriate medical reason as to why depression screening was not performed, such as dementia, or an urgent or emergent medical condition where a delay would jeopardize health. Next is the reporting period during which the quality measure applies. This is generally between January 1st to December 31st. And last are the data sources that will be used to calculate the quality measure. These data sources are generally billing codes and a manual review of the medical record to find the documentation and submit it to the insurance company. Now that we know the details of this quality measure, let's analyze its rationale and see if it's achieving its intended outcome. If I had to sum up the rationale for creating a quality measure for depression screening, it would be depression is very common and the diagnosis is often missed or delayed. And we need to ensure that doctors are screening and treating for depression. Now that we understand the basics of depression screening quality measure, let's look at the problems this quality measure creates for patients and frontline doctors. The most common depression screening tool used in primary care is a PHQ-2 or a PHQ-9. In primary care, this leads to an approximately 77% false positive rate, and that is when a cutoff value of 10 is used. But per the quality measure specifications, the cutoff used for depression screening is 5. Therefore, the false positive rate in real life is probably far higher. The requirement to treat a positive depression screen with a PHQ greater than 5 results in overdiagnoses and overtreatment of people. People can score positive for depression screening when something bad happens. Example, grieving for death in the family, divorce, job loss, etc. Due to the lack of insurance coverage for mental health therapy or the availability of mental health therapists themselves, most patients who screen positive for depression generally end up taking antidepressants, often for life. What this means is that depression screening measure in primary care is too sensitive, medicalizes normal variations in mood, and forces medical treatment on people who may just be having a bad day. While PHQ-9 has been translated into multiple languages, these translations have not been validated. These literal translations ignore cultural nuances in how mental health is perceived and expressed. For example, the meaning of questions like feeling down or little interest in doing things can vary significantly across cultures. This cultural mismatch can lead to both overdiagnoses and missing the diagnosis of depression. Also, we're taking a quality measure with approximately 77% false positive rate and forcing doctors to use it in people that speak a different language. This creates significant workflow challenges in a primary care office. So for example, the PCP office needs to find a repository of translated PHQ-9s to use. The medical assistant must remember to print the translated PHQ-9 and give it to the patient to complete. If the patient has difficulty completing, the medical assistant will need to coordinate with the interpreter to help the patients complete PHQ-9. Then, the PHQ-9 needs to be scanned in the EHR. Also, all the values need to be manually entered in the EHR for data reporting and collection purposes. Using interpreters costs both money and time. Most small practices use telephone interpreters, and they charge per minute. If medical assistants used interpreters to help patients complete a PHQ-9, then do we have the interpreter stay on call, incurring costs while the doctor is finishing up with other patients and has a chance to start the visit with the interpreter? Or do we have the doctor use an interpreter to help the patient fill out a PHQ-9 instead of actually taking a medical history, which is probably a lot more reliable? Using interpreters to provide good care is essential, but the requirement for depression screening increases the cost of running a medical practice without any meaningful improvement to care. Then there's the potential to harm patients. The depression screening metric mandates a follow-up plan if depression screening is positive. As mentioned before, given the lack of insurance coverage for mental health or the difficulty in finding mental health professionals, most people diagnosed with depression will end up on antidepressants. Antidepressants can have several side effects, including impacts on the stomach, heart, and brain. As a PCP, I've observed that antidepressants can significantly improve a patient's quality of life, but also cause serious harmful side effects. Balancing benefits and risks is crucial in medicine. However, quality measures incentivize a cookbook approach, penalizing doctors for not following standardized protocols, even if it may be inappropriate or harmful to individual patients. According to the Affordable Care Act, preventive care services such as an annual physical are provided at no cost to the patient. However, if a person screens positive for depression during an annual physical, the doctor needs to diagnose and treat depression to comply with the depression screening quality measure. This then becomes a billable medical visit and can result in substantial out-of-pocket costs for patients, especially those with high deductible plans. Also, when performing depression screening, PCPs often use a CPT code of 96127, which informs the payer that they performed depression screening. Often, this cost is also passed along to the patient. This creates a catch-22 situation. PCPs must use the 96127 code to receive credit for performing depression screening, but doing so often leads to people complaining about unexpected charges. Also, initiating treatment for a false positive depression screening adds burden to both the patient and the health system. So for example, increased costs for medications, mental health therapy, or other treatments that people will now have to pay. Furthermore, the cost burden is higher for people with high deductible health plans or those without coverage for mental health. Then there's the increased overall healthcare cost to the system for not only unnecessary treatments, but also to manage the harms from unnecessary treatment. And lastly, there's the resource allocation challenges. It's already hard to find mental health professionals today. If the limited capacity is used by people who scored a false positive on depression screening, this takes capacity away from people that really need mental health therapy. Not only are PCPs required to screen and treat false positive depression screening, but we are also subject to another quality measure, depression remission, at 12 months. This second quality metric measures how many people who scored positive on the initial depression screening were adequately treated, and now their PHQ-9 score returned to normal. That is, the PHQ-9 score is now less than 5 within 12 months of being diagnosed with depression. So essentially, even if the PCP did start a person on treatment, but the patient had a bad day at work on the day of their office visit with their PCP, and they scored a false positive on a PHQ-9, the PCPs failed to meet this second quality measure. In one sense, PCPs are now responsible for people's daily mood fluctuations that may result in a false positive depression screening and are required to treat that. Now that I've complained enough about depression screening, let's look at ways that PCPs can improve their performance on depression screening quality measure. The first task is to perform a depression screening. A typical workflow would involve creating encounter plans for specific visit types. So for example, annual physicals, Medicare annual wellness visits, or new patient visits. If the EHR is capable, it can send out a link via email or text message to patients who can then complete the PHQ-9 as part of the check-in. The encounter plan can also utilize dot phrases to automatically insert verbiage in the assessment and plan section, documenting that a depression screening was performed. Once depression screening is performed, it has to be reported to the insurance companies using billing codes. There's no clear guidance on which CPT and ICD-10 codes help doctors meet depression screening quality measure. The official CMS specifications do not specify any codes, while HEDIS specifications are proprietary and must be purchased from the NCQA. As far as I know, the CPT and ICD-10 codes listed on this slide, they are the most relevant. One way to achieve compliance could be that the EHR sends a link to the patient to complete a PHQ-9 prior to the office visit as mentioned before. Once a PHQ-9 is complete, the EHR automatically queues the appropriate CPT and ICD-10 code from the previous slide for the doctor or biller to review and drop the bill. Next is using HCPCS codes when billing Medicare. CMS defines a few HCPCS codes that are $0 codes to report quality. These codes indicate to CMS if the patient should be excluded from the denominator, and if included, if the physician met the metric. The EHR could use artificial intelligence to analyze the doctor's documentation and automatically queue the appropriate HCPCS codes. Let's get back to medical reality. Manual data collection and submission to insurance companies. Medical practices can submit supplemental data to health plans using reporting functionality in an EHR or from a data warehouse. The downside of this approach is that there's no way to capture a follow plan. However, this is still useful because a follow plan is not required for a normal depression screening. There's no way around the follow plan. This has to be collected and reported manually. However, AI has a role to play here and can simplify some of this manual labor. An example workflow could be a list of depression screening gaps in care is loaded in the electronic health record or the data warehouse. AI finds all the patients that have had a PHQ-9, and if positive, a follow plan has been documented in the medical record. This data is then fed back into spreadsheets to submit to insurance companies. Additionally, for proof, AI collates all the medical records containing a positive PHQ-9 and follow plan documentation in a format requested by the insurance company for submission. Depression screening does have a role to play in primary care, but only when it is used with the appropriate patient population. Making depression screening a quality measure and forcing it on all patients seen in primary care causes more harm than good, both for patients and PCPs. You can find a written version with references to the material that I discussed in this video on PCPlens.com. You'll also find an audio podcast version of this video on PCPlens.com. If you like this video, please sign up on PCPlens.com. Thank you for watching, take care, and goodbye.